Hi, welcome to Imaging in Pediatric COVID-19. I'm Summer Kaplan, a pediatric radiologist at the Children's Hospital of Philadelphia. No disclosures. So our objectives today are going to be to discuss how imaging of pediatric COVID-19 is different than adult imaging. We'll also consider maternal to neonatal transmission and introduce the idea of hidden health costs for COVID-19 in children. So COVID-19, as you know, is primarily a respiratory disease caused by the novel SARS-CoV-2 coronavirus. It's responsible at this point for over 500,000 deaths worldwide. Typically, it presents as fever, cough, fatigue, myalgias, can also present with headache, diarrhea, or conjunctivitis, and in some cases presents with blue toes or stroke, signs of vasculopathy and coagulopathy. Diagnosis is ideally made by PCR, which tends to be 60 to 91% sensitive. On lab assessment, it may also present with lymphopenia and elevations of C-reactive protein and procalcitonin. What we're going to discuss here today is how COVID-19 presents on imaging and the role of imaging in its diagnosis and workup in kids. So children are much less likely to have COVID-19 than adults. In the US, only 2% of our cases are pediatric. Children are also much less likely to have symptoms. However, there are some higher risk populations worth considering, and those include patients with comorbidities, especially lung disease, and patients who are younger. So younger than 1 year old tends to be a higher risk population. Overall, chest imaging is not recommended in the evaluation of COVID-19, but it may be useful in some cases, specifically if there's moderate to severe clinical features and testing is not performed or not available, if there are mild symptoms and risk factors for progression, such as those mentioned before, comorbidities or underlying lung disease, or if the clinical team is considering an alternative diagnosis. So the typical appearance of COVID-19 on chest CT in adults is characterized by bilateral, patchy ground glass opacities, which may also be nodular, and as the disease progresses, become more confluent and subpleural. However, children are much less likely to have this typical CT pattern. So children may present with a normal chest CT in about 35% of cases. When there are CT abnormalities, ground glass opacities are much more common, and consolidation may be present in 22%. However, the disease in children tends to be more unilateral, while in adults it's more bilateral. The images here show 3 generations of a family that presented with COVID-19. The 3-year-old female is asymptomatic, and you see that her COVID-19 manifests as a focal consolidation in the left lower lobe. The 30-year-old mother presents symptomatic and has a more typical adult distribution of peripheral, confluent, subpleural opacities. The 57-year-old grandfather, who's also symptomatic, presents with an even more typical adult distribution of bilateral patchy ground glass opacities that are predominantly peripheral with perihilar sparing. Lung ultrasound has been explored as a way to evaluate COVID-19. There are many attractive features of lung ultrasound, including its portability. So there's less contamination of staff and equipment. It may be more available, some places where CT is not so available. And there's less radiation than CT. So those are all reasons to consider lung ultrasound imaging. However, unfortunately, the lung ultrasound findings are not at all specific for COVID-19. So what we do see on ultrasound is an interrupted pleural line, like you see in the top image here. Patients may present with a whiteout of the lung, which represents a loss of the normal reverberations or A-lines that you see from the pleural reflection. People may also present with subpleural consolidation on lung ultrasound, demonstrated in the lower image in the corner. And in this image, the yellow arrows show us that there's some air bronchograms within that consolidation. So lung ultrasound does have findings, but they're not at all specific. And it's really unclear, even at this point, what role they have in diagnosis, management, and prognosis for the disease. Chest X-ray is really not sensitive or specific for COVID-19, and it's really most useful to look for alternate diagnoses. An unusual feature of COVID-19 that is specific for pediatric patients is multisystem inflammatory syndrome in children, or MIS-C. MIS-C is an entity that was discovered a few months into the course of the pandemic, when children began presenting with sort of a Kawasaki-like syndrome characterized by fever, GI symptoms, cardiac dysfunction, and hypotension. And like Kawasaki, many of them had myocardial dysfunction and coronary artery abnormalities. So typically, MIS-C presents 4 to 6 weeks after regional peaks in COVID-19 activity, but it may also present in a more acute phase. Interestingly, the preceding COVID-19 case in a child may be mild, and so the MIS-C may be really the worst of the child's COVID symptoms. They more often require hospital admission and ICU support when presenting with MIS-C. Chest radiographs do have a bit more utility in MIS-C patients. So unlike COVID-19 patients who are really characterized by a lack of pleural effusions, MIS-C patients often do have pleural effusions, and they also frequently have lower lung zone opacities. They may have an enlarged cardiac silhouette on chest X-ray, and that may be due to pericardial effusion or to cardiomegaly. So MIS-C is a multi-system inflammatory syndrome. So it includes not only pulmonary and cardiac abnormalities, but abdominal abnormalities as well. So on echo, patients may present with decreased myocardial function, with regurgitation through the valves, with pericardial effusion, coronary artery dilation, that kind of Kawasaki-like presentation, or cardiomegaly. And pleural effusions are frequently seen in MIS-C patients. Patients don't often get abdominal imaging, but when they do, abnormalities are often evident as well for MIS-C. So classically, those would be mesenteric adenopathy, mesenteric edema, bowel wall thickening, gallbladder wall thickening, and ascites. And MIS-C patients have also presented with CNS abnormalities, specifically in the corpus callosum. And like MIS-C, neurologic complications of COVID-19 were something that became apparent a month or so into the pandemic. So it was not really one of the things we recognized early on. So in kids, neuroimaging abnormalities also present a little differently than they do in adults. So when the neurologic abnormalities associated with COVID first became apparent, it was typically strokes occurring in adults, so coagulopathy in the setting of COVID-19. However, that's not how kids typically present with neurologic complications. So cerebrovascular disease is uncommon in pediatric cases. There are not a lot of pediatric cases reported. The largest series is 38 cases that were gathered by one of the neuroradiology societies, and include cases from around the world. The most common imaging finding in these cases was a post-infectious immune-mediated ADEM-like change in the brain. Patients also had myelitis. Some patients had neural enhancement with or without neurologic symptoms. And some certain findings were more common in the MIS-C patients. And those included lesions at the splenium of the corpus callosum, as well as myositis. Interestingly, actually, in these patients with neurologic abnormalities, pre-existing conditions were uncommon. So the immune-mediated ADEM-like changes present as in this 1-year-old boy who presented with seizure. And so on FLAIR imaging, there's subcortical confluent T2 hyperintense signal abnormalities, and the diffusion-weighted imaging shows restricted diffusion in a predominantly posterior distribution. Myelitis may present as in this 3-year-old girl who presents with respiratory failure, confusion, vomiting, and limb weakness. So in this image, we see T2 central cord hyperintensity that extends through a long segment of the cord. There's restricted diffusion, and there is some peripheral enhancement on contrast-enhanced imaging, as shown in this figure E. So both the diffusion restriction and the contrast-enhanced imaging increased over time. This patient was imaged 3 times, and those findings became much more apparent with time. Unfortunately, there were cases of atypical neural co-infections associated with some of these cases of COVID-associated neurologic abnormalities. So in 2 cases, tuberculosis manifested, and these were cases who did not have previously known tuberculosis. Another case had varicella and staphylococcal infection, and a 4th case had vasculitis related to fusobacterium and streptococcus. And so these cases with co-infection were all fatal, unfortunately. So because COVID-19 is much more common in adults, we have to be concerned about neonates contracting it from infected mothers. There's a systematic review of 36 papers published on this topic, and it turns out that vertical transmission from mother to neonate is actually rare, which is good. So in this series, the placenta tested positive for the SARS-CoV-2 virus in less than 1%, and really 4 in 1,000 patients. There was positive neonatal sputum or nasopharyngeal swab in a very, very small percentage of the infants. And there were no cases where the cord blood, the amniotic fluid, the vaginal secretions, or the breast milk was positive for the SARS-CoV-2 virus. So vertical transmission to neonates is exceedingly rare. Primarily, the risks to neonates are due to prematurity, due to mother's compromised health. And so low birth weight, ICU admission, and intubation are the most common challenges for neonates related to COVID-19. It's also important to consider other things that we may see as radiologists, as imagers in children in this era of COVID-19. So because of the social isolation and financial distress that a lot of families are going through, there's been an increase in interpersonal trauma, including child abuse. Mental health disturbances have become more common. And we see that families have failed to adhere to immunization schedules. So it's important to be aware of a potential rise in those diseases which we might not have thought of as commonly before. Late presentations of diseases are also becoming more common. So this is our quick tour of COVID-19 imaging in children. Thank you for your attention.